So much, Pascal, for that lovely introduction. And I am really very happy to be here this evening. It's afternoon in Boston. So I really appreciate you're all taking some time from your, I'm sure, very busy schedules to share this little bit with me. And I hope that this information will be useful to you. As Pascal said, I am happy to take questions at the end of the presentation. And so why don't we go ahead and get started? And I'm going to share my screen. Okay, hopefully you can all see this. So I am going to focus in my role as a pediatric sleep medicine provider on sleep in children and adolescents with migraines, but I will say that a lot of the information that I'm going to share is also applicable to adults with migraines as well. And in fact, much more of the research has been done in adults than in children and adolescents. So some of the points that I'm going to be touching on really come from the adult literature, and I'm extrapolating some of those points to also include children and adolescents. So what I'm going to cover this evening is some of the factors that impact the relationship between sleep and migraine headaches, especially in the pediatric population. And then to spend some time talking about the various sleep disorders that are associated with migraines in children and adolescents. And oftentimes, this information, as I mentioned, is extrapolated from adult data. So I'll talk a bit about insufficient, or what I call deficient sleep, and I'll define that in just a bit. Insomnia, restless leg syndrome, and periodic limb movement disorder, which I'll talk a little bit about exactly what that is. Narcolepsy, which is a central disorder of excessive daytime sleepiness. And then a group of other sleep disorders that have been linked to an increase in the frequency or chronicity of migraine headaches. And then I'm going to talk a little bit about screening for sleep issues in children, which also is applicable to the adult population. So I want to start out with something called the two-process model of sleep regulation. And I don't want to get too far into the weeds with this, but I think it is always very helpful for my audiences to understand something that is very basic about how sleep and wake occur throughout the 24-hour day. So the first process that we talk about is the sleep drive. And the sleep drive essentially is stronger the longer you've been awake. So the longer you're awake, the sleepier you get, and the stronger the drive towards falling asleep. Now, on a natural or normal circumstance, that sleep drive is dissipated, as shown by these orange arrows, over the course of the time that we're asleep at night. Now, there's also another very important process which regulates sleep and wakefulness, and that is the circadian drive towards alertness. And that is a fairly predictable series of relative peaks and troughs of alertness and sleepiness that occur throughout the day. So, for example, when we wake up in the morning, our homeostatic sleep drive is hopefully low because we've gotten a good night's sleep, but our circadian drive towards wakefulness is also fairly low. And then around mid-afternoon, 3 to 5 p.m., when some cultures take siesta, we actually experience a dip in our alertness as a result of the circadian system. Now, there's something called the forbidden zone, which is the time period about an hour before our brains are ready to fall asleep, in which we actually have a surge in circadian-based alertness. And that probably is built in to allow us to stay awake for that additional period of time in the face of an increasing sleep drive. And then the lowest point of circadian alertness occurs when most of us are asleep between 3 and 5 in the morning. So I think it's also critical to understand that both the amount of sleep we get and the timing of sleep are very important from a biological perspective. So we now know that in addition to a master clock in the brain, in what's called the SCN or suprachiasmatic nucleus, if you want to use a fancy term, each cell in the body possesses a circadian clock, which must be synchronized with one another and also with the external environment. So the most powerful clue or cue to the circadian system is light. So light suppresses the brain's release of melatonin, which we call the hormone of darkness or the biomarker for the circadian system. And darkness allows for the release of melatonin by the brain. And a mismatch or misalignment between this internal circadian clock or clocks and the external light-dark cycle can result in profound impairments in physiologic function, cognitive function, mood, and health. So just something to keep in mind that the circadian system is really incredibly important in keeping us healthy and functioning. So deficient sleep is a concept that includes both short sleep duration. So in other words, compared to your sleep needs, and those change quite a bit over our lifespan, and circadian misalignment, that mismatch between biologically based circadian rhythms and the demands of the environment, while these are interrelated, may both contribute to the behavioral and cognitive impairments and poor health outcomes. In other words, from a simplistic standpoint, it's not just how much you sleep, but when you sleep. That's really critical. And that will come to light when we talk a bit more about how sleep affects migraine headaches. So sleep is definitely a risk factor for some conditions that impact headaches and impact brain function in particular. So in terms of recovery from an acute injury, so something called mild traumatic brain injury, which is also known as a concussion, is associated with sleep disturbances in that these sleep disturbances can come before the injury, can exacerbate the response to the injury, or perpetuate some of the outcomes of concussions, including depression, post-traumatic stress disorder, chronic pain, and as a result, impair rehabilitation from these types of brain injuries. And pre-injury migraines may also be a risk factor for worse concussion outcomes. So, in other words, if you have both a combination of sleep disturbances and a history of migraine, this might result in worse outcomes after a subsequent brain injury like a concussion. Now, we know that sleep has a profound impact on pain, and that there is a very important bidirectional relationship between poor sleep and the perception of pain, the intensity of pain, and also having a decreased threshold for experiencing pain and for tolerating pain. For example, many chronic pain conditions like fibromyalgia or juvenile rheumatoid arthritis, sickle cell disease, and migraines, in those cases, sleep can impact an increase in pain flares, in exacerbations, in the intensity of the pain, and also functional disability. And in fact, chronic exposure to insufficient sleep or frequent awakenings, disrupted sleep during the night, has been reported to decrease habituation to painful stimuli and to increase alterations in the pain inhibitory systems, both of which can potentially favor chronification of headaches of all types, including migraines. Now, in addition to this, sleep may have a specific act as a risk factor for migraines. And again, these studies are principally in adults. And we know that migraineurs have worse sleep quality than non-migraineurs. And self-reported poor sleep quality is associated with an increased frequency of attacks or chronification of migraines. And in addition, preventive migraine treatments might improve the quality of sleep. So again, we have this bidirectional relationship between sleep problems making migraines worse, migraines making sleep worse, and breaking that cycle becomes a very important goal for treatment and management. I came across this diagram in a very recent study that it's a very interesting paper that talks about a biopsychosocial model to migraines. And I think really underscores the importance of all these relationships with brain function, levels of disability, chronification of headaches, impaired response, heightened levels of disability, again, and having all these other factors interact with these various parameters related to chronic headaches, including the presence of mental health issues and other chronic pain syndromes, obesity, which I'll talk about a little bit in a bit, inflammatory diseases, all contributing to these cascades. And again, you see these arrows are really bidirectional in terms of underlying medical conditions and external stressors, which all can contribute to altering pain processing circuits and thus increase the frequency and prolongation of migraine headaches. So I want to talk a little bit about adolescents because deficient sleep is particularly prevalent in this population. And there are several reasons for that. So all adolescents experience a normal circadian-based shift or delay of up to several hours in the time that they naturally fall asleep and they naturally wake up compared to when they were younger. And this occurs with the onset of puberty. So it can affect adolescents who are as young as 10 or 11 years old. Now, the other thing that happens in adolescence is the accumulation of that sleep drive that I talked about earlier actually slows down. And so it's easier for adolescents to delay going to sleep because of this combination of circadian factors and the sleep drive slowing down. Now, this circadian phase delay, this normal shift in fall asleep and wake time, is further exacerbated by evening light exposure, in particular blue light from screens. And so not only are adolescents more likely to use these screens that emit blue light and in turn suppress your brain's release of melatonin, but they're even more sensitive than younger children to the effects of that evening light. And so what we very often see is what we call weekend oversleep or social jet lag. So this is the process by which adolescents go to bed later on non-school nights and sleep in an attempt to compensate for not getting sufficient sleep during the week. And this in itself further contributes to circadian misalignment and exacerbates the whole problem. Now, of course, there are other competing priorities for sleep among adolescents. That's very clear. And those include a range of different factors like social networking, homework burden, extracurricular activities, and at least in the US, a very important factor which results in deficient sleep in adolescence is early school start times. Because not only does that early start time prevent adolescents from getting the amount of sleep they need, they're also being asked to wake up and function at a time which for them is their circadian nadir. Remember that 3 to 5 a.m. dip in alertness. Well, that is the lowest point of alertness in a 24-hour day, and that's exactly when we're asking adolescents to wake up and function at their highest level. So because of the circadian misalignment and insufficient sleep, adolescents also get reduced early morning sleep. And why that's important is because REM, or rapid eye movement, or dream sleep principally occurs in the last third of the night. And we know that REM sleep is very important for memory consolidation. And so reducing the amount of REM sleep that you get can also affect functionality, particularly in terms of academics. So for optimal health, safety, and achievement, the average middle and high school student needs 8 to 10 hours of sleep per night. And we know that most adolescents don't get nearly as much. And I think that's probably true in Ireland, just as it is in the United States. Now, how that relates to migraines is that, for example, we know that sleep disturbances and these changes in the sleep schedule that occur during adolescence that can be migraine triggers clearly increase before and after the onset of puberty. So these same triggers, these same normal changes in adolescent sleep can also contribute to increased triggers for migraines. And sleep disturbances also increase pre-puberty to post-puberty as prodromal symptoms of migraines. So to a very high level of 87% in the post-pubertal adolescents. And we're beginning to understand more about the relationship of migraines with circadian timing, so that they're more likely to occur in the early morning or late night, and how that relates to neurotransmitters like serotonin in the brain, and also sleep stages, such as REM sleep. So that we're just beginning to understand those more complex relationships between the different stages of sleep and circadian timing and neurotransmitters that will hopefully, as we gain more of an understanding, will lead to better treatments and allow us to really delve more into these relationships between sleep and migraines. Now, in terms of potential solutions here in reducing risk for migraine. So this was a very interesting study, near and dear to my heart, that compared migraine frequency in high school students who had early school start times, earlier than 8:30 a.m., versus later start times, i.e. later than 8:30 a.m. And they saw, as many studies have already demonstrated, that the self-reported school night sleep duration in those students who were attending early starting schools was about 7 hours versus 8 hours in those students who were attending schools that started later than 8:30. And the mean frequency of self-reported headaches was 7.7 days per month versus 4.8 days per month, which was statistically significant in the earlier starting versus the later starting high school students. And this remains significant after they adjusted for gender, homework amounts, use of medication, and grade levels. And the authors concluded that if prospective studies confirm this finding, then shifting to a later high school start time, among many other positive benefits, may be an effective strategy for migraine prevention in the adolescent population. Now, when we start to talk about specific sleep disorders, I think there certainly is an awareness that insomnia or difficulties initiating sleep, falling asleep, or maintaining sleep, staying asleep, and also in some cases waking too early, has an association with migraines. And so in adults, there is a significantly higher prevalence of insomnia and insomnia complaints documented in patients who have migraines compared to those without headaches. And a higher prevalence of migraine has been reported in subjects with insomnia compared to those without. So again, it works in both ways. And in adolescents, as a specific population, up to 50% of patients with migraines report insomnia, which is much higher than in the general population, although insomnia is unfortunately a frequent complaint in adolescents as well. And patients with migraines had more mood issues, dysthymia, which is a milder form of depression symptoms, sleep disturbances, and excessive daytime sleepiness that seem to be associated with caffeine use, but not with an increase in levels of the neurotransmitter serotonin, which has been implicated in the underlying pathophysiology of migraine headaches. And insomnia also seems to increase the risk for persistence of migraines, for progression from episodic to chronic status, and may also even predict next day onset and severity of migraines. So similar to what we see with the relationship between insomnia and depression, treating the insomnia may also significantly improve the frequency, the intensity, the chronification of migraine headaches as well. And this is important because treatment of insomnia is not just about taking medications, sleep medications, or hypnotic medications. There is a very specific behavioral package treatment for insomnia called cognitive behavioral therapy for insomnia that is now recommended as the first line treatment for insomnia above use of medications. And so there is an opportunity for patients who have insomnia not to necessarily take medications, but certainly if they do, to combine the medications with CBTI or chronic behavioral therapy for insomnia. And CBTI really focuses on behaviors that people with insomnia engage in order to try to help their insomnia, but often make it worse. So something like napping during the day, which takes the edge off your sleep drive and creates a situation where you have more difficulty falling asleep that night, or lying in bed for hours worrying about not being able to fall asleep. So that's where the cognitive piece comes in, because many times people who have insomnia become very anxious about not being able to fall asleep. And if in addition they're more likely to experience migraines, well, of course, that's an even bigger reason to feel anxious about that relationship. So CBTI, which is practiced oftentimes by psychologists who specialize in behavioral sleep medicine, is really critical. Now, in terms of insomnia in children, school-age children with migraines have a higher prevalence of a decrease in total sleep time, lower sleep quality, and increase in excessive daytime sleepiness. Now, this was a second point, was an interesting study which showed that parental migraines had a negative impact on adolescent global well-being, including sleep. So in other words, these are adolescents who did not themselves experience migraine headaches, but had parents who did have migraines that also affected the adolescent sleep. Interesting. And maybe there's some genetic component there that we don't yet know much about. Now, PSG or polysomnography, that is a sleep study. And so data in children with migraines have shown some differences in what is called their sleep architecture. So they tend to have a lower percentage of REM sleep, rapid eye movement sleep. And remember, that's the type of sleep that is very important for memory consolidation compared to children who do not have migraines. And they tend to have less in total sleep time, more wake after sleep onset, and a shorter time to fall asleep. So there are some actual differences when we measure sleep objectively in children and adults with migraine headaches. Now, I mentioned CBT, and this was a very interesting study that looked at what was called a hybrid cognitive behavioral therapy for adolescents with both insomnia and migraines. So this hybrid cognitive behavioral therapy simultaneously targets both conditions. And this in particular, conditions that are known to contribute to the onset and maintenance of chronic pain. So the treatment intervention was 6 individual sessions, which first talked about sleep hygiene or healthy sleep practices, things like not drinking caffeine after 4 o'clock in the afternoon, or not compensating for poor sleep by napping during the day. They also use something called sleep restriction, in which the patient is instructed to only spend as much time in bed as they're asleep. And that really is designed to prevent being in bed and associating that with being awake instead of asleep. And stimulus control is a similar kind of intervention, which avoids that association with bed and wake and promotes the association of being in bed with sleep. Now, in this particular study, they found that immediately post-treatment, the mean number of days with headaches declined from 4.7 to 2.1. Insomnia symptoms improved significantly and were sustained at a 3-month follow-up. And they also saw improvements in pain-related activity limitations. So, in other words, not only did the number of headaches go down and the insomnia symptoms improve, but the limitations on functionality also improved with this hybrid treatment. And they found that in general, there was good adherence or compliance with treatment, and it was acceptable. So again, this really underscores the importance of seeking out these kinds of behavioral interventions to address both sleep and conditions of chronic pain. Now, shifting the gears a little bit to talk about restless leg syndrome. So this is a chronic neurological sensory motor disorder that is characterized primarily by the urge to move the legs, sometimes the upper arms body as well, that is usually accompanied by uncomfortable or unpleasant sensations. People may describe it as pain, but it's more often my legs just feel funny, or I feel like I need to move them. And these symptoms begin or worsen during periods of rest or inactivity and tend to occur or be worse in the evening and the nighttime. And thus that results in difficulty falling asleep because of the timing of the symptoms. And the symptoms are partially or totally relieved by moving the limbs, at least as long as the activity continues. Now, people with restless leg syndrome also oftentimes have what we'll call periodic leg movements, and these are flexion or kicking movements that occur during sleep and disrupt sleep, that have a specific duration and amplitude, and they occur in sequences and can only be reliably diagnosed with an overnight sleep study. But what's important also to understand is both of these conditions are highly associated with a genetic or familial predisposition and also with iron deficiency. Now, available evidence really suggests the existence of a strong bidirectional relationship between restless legs and migraines. So the prevalence of migraines in patients with restless legs ranges from 12% to 53% and is significantly higher compared to individuals who do not have RLS. On the flip side, the prevalence of RLS in subjects with migraines ranges from 13 to 25% and is significantly higher compared with those without migraines, and also to subjects with other types of primary headaches. So the presence of restless legs appears to be associated with a higher migraine headache severity level, associated symptoms with migraines, higher level of disability related to migraines, and higher scores on depression and anxiety scales than those without restless leg. while the presence of migraine itself was not associated with significantly higher restless leg severity. So in terms of that severity relationship, RLS seems to confer an increased severity and increased disability on patients with migraines. And the positive association between restless legs and migraine has been hypothesized to be due to a shared dysfunction in the synthesis of a neurotransmitter called dopamine, which appears to be affected in both patients with migraine and with restless leg. And the reason that iron is important in that relationship is that iron is a rate limiting step in the synthesis of dopamine. So many patients with restless legs have low iron levels, and their symptoms are significantly improved by iron supplementation. Now, again, to talk about a different sleep disorder, narcolepsy, there are two types of narcolepsy, type 1 and type 2. And narcolepsy is primarily characterized by excessive daytime sleepiness. And we oftentimes use a scale called the Epworth Sleepiness Scale to assess the level of sleepiness rather than fatigue that someone has. So sleepiness is really the tendency to doze off or fall asleep, particularly under conditions of low stimulation. So the Epworth Sleepiness Scale asks the patient to rate how likely they would be to fall asleep or doze off under a series of 8 different situations, like watching television or sitting and reading. So excessive daytime sleepiness is really the inability to stay awake and alert during the major waking periods, so the time when we're supposed to be awake during the day, that results in periods of an almost irresistible need for sleep or unintended lapses into drowsiness or sleep. Now, type 1 narcolepsy is also associated with what's called cataplexy, which is a brief episode of sudden, short-lasting, bilateral, symmetrical loss of muscle tone that is usually triggered by strong emotions, particularly laughter. And the individual who's experiencing these cataplexy attacks has a retained consciousness. So they're aware of their surroundings, even if they're unable to move. Type 1 narcolepsy is also associated with sleep paralysis, which is the inability to move for a brief period of time on either falling asleep or waking up. And these patients may also experience hallucinations, visual or auditory hallucinations during that time of sleep paralysis. And they also tend to have very disrupted sleep. And one of the issues with narcolepsy, both type 1 and type 2, is that the diagnosis is often very significantly delayed. And many of these patients are diagnosed with psychiatric conditions or neurological conditions for many years before they're finally appropriately diagnosed with narcolepsy. And type 1 narcolepsy in particular has been very clearly associated with a decrease in the neurotransmitter orexin, also known as hypocretin, in the brain. So we know that the prevalence of migraines is higher among patients with narcolepsy, and the onset of narcolepsy symptoms in one study occurred on average about 12 years before the onset of migraine symptoms. Another study showed that migraine prevalence was significantly increased in patients with narcolepsy and also patients with what's called idiopathic hypersomnia, which is a condition which is characterized again by excessive daytime sleepiness, but not the other features of narcolepsy, such as cataplexy. And you can see that those percentages are much higher compared to healthy controls. And so it's an interesting hypothesis that the pathophysiologic mechanisms of both narcolepsy and migraines may converge and actually involve this orexin system, orexin or hypocretin neurotransmitter system in the brain, which again opens up the possibility of, in this case, pharmacologic treatment, because there are now medications which are targeting the hypocretin orexin system that could be eventually helpful for patients with migraines as well. Now, in terms of other sleep disorders, we don't really know a lot about the relationship between what's called sleep disordered breathing, or more commonly obstructive sleep apnea, and migraines. But we do know that obesity is a risk factor for both obstructive sleep apnea and especially for chronic migraines, probably related to systemic inflammation. So we know that obstructive sleep apnea causes inflammation throughout the blood vessels of the body, and obesity is also related to that same inflammatory response. So that is a relationship that I think is quite intriguing and has, reason to further explore. We also know that the frequency of migraines and other chronic headaches are more common in individuals who are shift workers. So people who are shift workers, particularly if they have rotating shifts, are more essentially have a condition of circadian misalignment on a chronic basis. And we know that shift workers are more likely to have a number of different medical conditions, including obesity, type 2 diabetes, and even certain types of cancer. Migraines also seem to be associated with persistent nightmares that began in childhood for reasons that I think we certainly don't completely understand at this point. And interestingly enough, adult patients with migraines are more likely to have a current history of sleepwalking and a childhood history of sleepwalking. So what that relationship is all about probably also has something to do with alterations in neurotransmitters as well. So what providers and those of us, and I have only had one migraine headache in my life, and I will remember it very vividly. But I think we have, certainly healthcare providers have an obligation to screen patients for their sleep patterns, their amount of sleep that they get, daytime sleepiness, not only at every well-child encounter, but every time you go in for your annual physical exam as well. And asking about things like drowsy driving, in which people are more likely to have car accidents, including fatal car accidents, if they have an underlying condition that causes insufficient or deficient sleep, as well as asking about environmental influences that may negatively impact on sleep, such as excessive use of electronic media and screens, particularly just before bedtime, and excessive caffeine consumption, but also considering deficient sleep as a factor in all patients who present with a whole host of different complaints, including academic failure, depression, risky behaviors like substance use, obesity, and migraine headaches. So asking about patients about their sleep when they have migraines is really a critical piece, as well as you as the patient being aware of those relationships. And as providers, we need to inform caregivers and patients about the warning signs and potential impact of deficient sleep as part of talking to patients. In pediatrics, we call it anticipatory guidance, which is talking to parents and caregivers about, well, before the next annual checkup, these are the kinds of things that you need to be aware of and be looking for. Just in general, discouraging nighttime use of electronic media. As adults, many times we buy into this idea that we need these screens in order to fall asleep. But I always think about my patients who come in who are taking melatonin to help them fall asleep. And at the same time, they're glued to screens, which is suppressing their brain's release of melatonin. So it's a zero-sum game, basically. And in particular, to include and prioritize sleep as a pillar of health that's just as important as physical activity and good nutrition and all those other things that we do to keep ourselves healthy.